Welcome to week 11. And in this week, we're going to be covering both the male and female reproductive systems and the disorders that can occur in them. Usually, when I give this lecture in class, no matter how hard I try, there are still giggles that occur, even with the adults. Of course, I never get this with the recording that I make for people online, but anyway, I know some of you will still be giggling, or maybe not so much if you're all by yourself, but anyway, it's a good thing that I'm doing this now. I'm going to be flying uh, later tonight or actually later tomorrow. And it wouldn't be good if I was trying to record this in the airport. So let's get started. First of all, you have to realize if we talk about the male genital and reproductive system, we have to consider the fact that actually the urinary system is part of the genital system. And so we do refer to it as the genitourinary tract. And so both the kidneys and the ureters are actually part of the upper genitourinary tract, and the lower GU tract, of course, is going to then involve the bladder, urethra, prostate, seminal vesicles, the glands, and the external genitalia or genitalia, depending on where you grew up. And your textbook starts off with a little bit of anatomy in terms of where the ureters enter and their shape and how far apart they are and where things arose from the mesoderm. I'm not really concerned about that. One of the things, of course, that's very important for the male GU tract is the blood supply, and this is coming off of the hypogastric artery. And of course, we have to have a nice picture. And so we have a picture showing this rather nicely with of course, the bladder and the prostate and everything. And we'll get into a little bit more detail, but I never spend a lot of time on the anatomy. That's suitable for other courses. And by now, I would think you guys pretty well know your anatomy. Nervous supply, of course, is extremely important for the male GU tract, and both sympathetic fibers and parasympathetic fibers are involved. And we'll talk a little bit more about that when we get into the actual function. And we do have, this is actually kind of a nice picture, kind of summarizing where the nerve fibers are coming from, and then the afferent and then the efferent, and kind of gives you an idea, and where, of course, they're coming out of the spinal cord and then affecting the bladder and this sort of thing. Now, as we discussed last week, the urethra does extend from the bladder to the tip of the penis, and it functions obviously as a conduit for the urinary system, but also for the genital system. And in man, it is divided into three segments where you have the prostate, the seminal glands, and the urethral glands. It's going to be one of those recordings, I guess. So we'll start off with talking about the seminal vesicles and the vulvourethral glands. And the seminal vesicles are paired organs that are next to the prostate and secrete the fluid that is very important for the sperm, for the survival of the sperm. The vulvourethral glands are located on each side of the membranous urethra, and they secrete this mucoid fluid, which is also important for the sperm. And this is a pretty nice picture of it, very clearly showing where they are located in terms of going from the bladder down the conduit, the urethra, into the penis. The prostate lies actually behind the bladder, and it is, as it says, both muscular and glandular, weighs only about 20 grams, and is not really all that wide and this sort of thing. Does have a capsule, and as I said, it's got the muscle and some collagen tissue, and the actual interior of the tissue, the stroma, if you will, contains the epithelial glands. These epithelial glands will drain directly into the excretory ducts, and therefore the prostate gland can be considered part of the reproductive organ. It really definitely is. And again, the prostate and seminal vesicles produce the fluid that really supports the survival of the sperm. And the blood supply is coming from the inferior vesical artery, which is a branch of, as we've already identified, the hypogastric artery. And of course, there are additional supply to these portions in terms of the blood supply, which are very important, but we're not going to go into that just yet. Right now, we're going to do a rather quick discussion of the male external genitalia, starting with the scrotum, which is basically the sac. This is carrying, it lies below the penis and the pubic symphysis. And it's basically connective tissue that separates the sac into two compartments. And this is where the male testes, the epididymis, and the lower portion of the vas deferens is, of course, located. The scrotal sac then will support the testes and regulate temperature, and is going to relax and contract the muscular layer. And that, of course, will affect blood flow and affect temperature. The testes, as I've already said, lie within the scrotum, and they are suspended by the spermatic cord. Sperm production occurs in the epithelial lining of the specific tubules, the seminiferous tubules of the testes. And the seminiferous cells may be supporting cells or spermatogenic cells. So they will produce things that support the cells and production of sperm, and the spermatogenic cells, of course, actually are producing the sperm. And then there are also the Leydig cells, which are embedded in the seminiferous tubules, and they produce the testosterone. The epididymis is just a coiled duct, and it will be located behind each of the testes, and it helps to conduct the sperm from the efferent tubules to the vas deferens. Penis, of course, is the male organ of copulation and urinary excretion. It has three erectile bodies, two what they refer to as corpus cavernosa and one corpus spongiosum. All three of them become engorged with blood and enlarged during an erection. And the arterial blood supply is provided now by the paired internal pudendal arteries, both, of course, are branching off of the hypogastric artery. Venous drainage, then, well, which is very important, will occur through several channels. Now, as mentioned earlier, nerve supply is very important and is provided by both the parasympathetic and sympathetic systems. The parasympathetic is important in relaxation, vascular resistance. So it's going to open up the blood vessels, which will increase blood flow to the penis, and this is what creates an erection. The sympathetic nerve fibers may contribute. There are many people who think they do, but they don't really understand and have not really proven that. However, we do know that the sympathetic nerve fibers do contribute to ejaculation of the seminal fluid into the actual urethra, so they are important. And this is obviously a picture demonstrating the various blood vessels, and then also coming in, so the arterial supply, and then the venous drainage on the right. The internal male genitalia will, of course, consist of the ducts, the two vas deferens, the ejaculatory duct, and the urethra. This is conducting the sperm and glandular secretion produced by the glands from the testes then to the urethral opening of the penis. And the glands, the prostate, the two seminal vesicles, and the bubble urethral glands, all are secreting fluids that are very important, not only for the transport of the sperm, but also to help feed them. It's very important that the sperm get proper nutrients temporarily. This improves motility and survival. And so it's really the combination of the sperm and the various secretions that form the semen. And this is kind of a nice cross section showing you where the genital urinary system, how it is positioned in the male body. And you can see, of course, how both the exterior and interior are connected and their connection with the urinary system. Now, I want to spend a little bit of time talking about sexual differentiation in utero. Your book, in this particular version, goes into a little bit more detail than I want to, but it's still kind of nice to get an idea of how this happens because it really is part of the miracle of life. So, what happens as a child is developing, the reproductive structures of both male and female very early on are exactly the same. They both have one pair of primary sex organs, known as the gonads, and two pairs of ducts, the Wolffian and the Mullerian. Both ducts will, of course, empty into the urogenital sinus. The external reproductive structures develop then, both the male and the female, from the same genital tubercle. Testosterone, not surprisingly, will convert the genital tubercle into male genitalia, and the absence of testosterone or the presence of placental estrogen will convert it into female genitalia. And by 9 months, all of the internal and external structures have formed, and the testes have descended into the scrotum. Now, going into a little bit more detail, when we talk about male embryos, of course, the men have a Y chromosome, and there's a particular gene on there called the testes determining factor. It's on the Y chromosome that will lead to the production of testosterone by 7 to 8 weeks of gestation. So, very early on, the testosterone is produced, and that, of course, will induce the male gonads to become testes, I should say, which produce the sperm. As a result, the Müllerian ducts will degenerate and the Wolffian ducts develop into the vas deferens. And then, of course, those are the tubes that carry the sperm to the urethra. In contrast, female embryos, of course, the gonads are going to be producing estrogen, and it seems more that the absence of testosterone induces the gonads to develop into ovaries, and which, of course, are going to produce the ova. The Wolffian ducts, however, in women will degenerate and the Müllerian ducts develop into the fallopian tubes. Again, with the same sort of function, actually, though, producing the ova instead of the sperm to the uterus. Penis, of course, is the male organ of copulation and urinary excretion. It has three erectile bodies, two what they refer to as corpus cavernosa and one corpus spongiosum. All three of them become engorged with blood and enlarged during an erection. And the arterial blood supply is provided now by the paired internal pudendal arteries, both, of course, are branching off of the hypogastric artery. Venous drainage, then, well, which is very important, will occur through several channels. This never fails to surprise me, but actually, the development of the external genitalia begins very early at about 12 weeks. And these genital swellings will migrate and fuse to form the scrotum. And then the tubercles elongate to form a cylindrical shape. And this, of course, the groove becomes covered by folds of tissue to form the penile urethra. And this picture kind of shows you the difference between the development, again, of male and female with that. And that's about as much as I want to go into this early development of the reproductive tracts. However, we do need to talk a fair amount about, of course, the hormones that are involved. And gratefully, in men, it's a little bit easier than it is in women. So, looking at the hormonal control in men, there you have to take into account what's known as the hypothalamic pituitary testicular axis. So now, the hypothalamus is going to be the center that coordinates messages from the rest of the brain and from the bloodstream, the humoral messages from the testes. So, when the testes release hormones and stuff, all right? And what the hypothalamus will do is control the release of gonadotropin releasing hormone. The pituitary stalk then provides the route for the releasing hormone to move. And then when that comes down to the pituitary will produce luteinizing hormone and follicle stimulating hormone. Luteinizing hormone will mediate testosterone synthesis, so it helps to stimulate it. And when testosterone is produced, then it is released into the bloodstream to have its multiple effects on different organs. Other steroid hormones that will participate, dihydrotestosterone, actually differentiates and matures the male external genitalia and the prostate, and is very much increased in puberty. And then 17-hydroxyprogesterone is important as well as estradiol. We don't really know the function of follicle stimulating hormones in males, but we do know a small amount is produced. And sperm requires, however, the presence of high levels of the androgens and follicle-stimulating hormones. So there must be some role that it has. Feedback inhibition mechanisms will then control the secretion of LH and FSH. So if those get really elevated, they will then feedback and control their release. And in particular, production of luteinizing hormone occurs in response to serum levels of testosterone and estradiol. So when those get elevated, the production of luteinizing hormone is affected. There are other substances that can affect the production of these hormones, particularly inhibin, and sex steroids may modulate FSH production. Now, this is all very interesting, and if you were to specialize in this, you'd need to know it in a little bit more detail. I'm just trying to get you a little bit familiar with it. We're not going to talk that much about it because there aren't that many disorders really in men as a result of this. Uh, Except unless, of course, they have a pituitary problem or experienced trauma to the brain and the central nervous system, so the hypothalamus, this sort of thing. This is a nice little picture here of looking at the hypothalamus and any kind of feedback inhibition. And I am certainly not going to test you on it. So if you're interested in this sort of thing, take a look at it at your leisure. But for the purposes of this course, you can just kind of go, oh, well, this is cool. I'll look at it later. The male sex hormones, though, are all androgens, including testosterone. Again, they're produced by cells of the testes known as Leydig cells or Leydig. It all depends on, again, where you grew up. And the adrenal glands produce also the adrenal glands will produce testosterone. So both of those will. Sex hormone production in men is fairly constant. That's one thing they don't have to worry about so much. But there is a certain amount of diurnal variation, but nothing like what women experience. This leads us to a discussion of spermatogenesis. It begins early in a man's life at puberty and then continues for the rest of his life. Takes place within the seminiferous tubules of the testes, which starts out as diploid spermatogonia or germ cells, will undergo continuous mitotic division to eventually form haploid gametes. So some spermatogonia will become primary spermatocytes, which then will undergo meiosis to form two haploid cells called secondary spermatocytes. The secondary spermatocytes undergo the second step in meiosis, and these will form the spermatids that are actually haploid and differentiate into spermatozoa or sperm. This is just a picture from your textbook kind of showing you where spermatogenesis occurs and the steps in meiosis that lead to the formation from a single cell into form 4 sperm cells. Testosterone is, of course, is required for this process, but testosterone has a lot of other effects as well. It promotes skeletal growth, is going to also promote growth of the larynx and the musculature and this sort of thing. So that's why the guy's voices get deeper. Also will stimulate bone marrow and indirectly increase production of erythropoietin by the kidney. Will also, unfortunately, at puberty stimulate the sebaceous glands, which is why they have a problem with acne, but we have very good medication for that now. Will alter hair growth so that you get a male pattern of hair growth. It contributes to the male pattern baldness, but actually, male pattern baldness is more of a genetic thing than just as a result of the effect of testosterone. And it is, of course, required for the production of sperm and, of course, a man's libido. Sperm are themselves about 60 microns in length, so they're pretty small. They do have that oval head, which has DNA in a highly condensed form. It also has what's known as an acrosomal cap, and this is really a protective cap that is resistant to physical injury as the sperm move. And the tail counts for about 90% of the length. It is highly motile due to this axoneme, which is actually a pair of tubules that are in the tail. And this can twist, which will help to kind of whip the tail and propel the sperm forward. Mitochondria are present, although not as much as they are in the ova, and they contain enzymes, of course, for ATP production, which is also helpful for fertilization of the egg, as it says. Well, the sperm have to be transported from the testes to the penis for ejaculation and this sort of thing. So they pass through the Sertoli cells and into the duct, and they travels from the seminiferous tubules to the retesti and through efferent ductals to the epididymis, and that goes through the epididymis and enters the vas deferens before entering the ejaculatory duct. And there's, of course, muscles in the vas deferens, which helps to push the sperm forward. And the epididymis itself sustains the maturational process because the production of certain secretions and this sort of thing. And the sperm itself will also then, although they are capable of movement on their own, are transported in part by rhythmic contraction. Typically, there are about 200 million sperm in the reservoir of the epididymis, and then the rest are found in the cauda region. And with ejaculation, of course, the sperm from the distal part of the epididymis and the vas deferens are deposited in the prostatic urethra. Now, erection, of course, vascular supply is very important, and all three of the channels, the corpora cavernosa and the spongiosum, will fill with the blood. This is definitely important with parasympathetic stimulation, but also sensory and motor innervation. Hormonal factors such as prostaglandins could contribute, as well, of course, as psychogenic stimulation through the central nervous system. And there, of course, is also local stimulation through the sacral spinal cord. Now, when I don't want to emphasize things too much, I put way too much on a slide, which is what you're seeing here. But, and this is not to say this is unimportant, but I just want you to get a general idea. I'm not going to test you on details with this. But ejaculation, not surprisingly, has at least two phases. Right now, that's how they put it. Emission and ejaculation. Emission is basically pulling together the secretions, the various secretions from the different glands, along with the sperm. And then ejaculation, you have actual external sphincter relaxation, and the muscles will contract to expel the semen or the ejaculate. Then there's something that's kind of interesting that occurs is known as capacitation. And this will actually, there are a number of changes that occur as the sperm is moving through that will activate them. And this activation actually is very important for their ability to participate in fertilization. It occurs in about 1 to 10 hours. And then fluids from the vagina and fallopian tubes will wash away inhibitory factors that actually suppress their activity. So once the ejaculate is there, these fluids will help to activate them. And what this does is, in part, make the sperm head more permeable to calcium ions. Well, what that's probably doing as part is activating the calcium transporters. Calcium gets in. Calcium, of course, is important for muscle contraction. Well, in sperm, it's important for tail movement. This then helps to allow the tail to move and facilitate the movement of the sperm and potentially into, of course, the ova. And then we can also talk about this acrosome reaction. Now, remember, the acrosome is sort of this protective head covering for the sperm. And the acrosome, stored within it are all these hydrolytic enzymes that, not surprisingly, once the sperm are activated during this capacitation, I should say. And what do the enzymes do? Well, they help to break down cervical mucus to allow the sperm to pass into the uterine tubes. And then right prior to fertilization, the sperm have to penetrate this layer of cells, the granulosa cells and the zona pellucida. And one of the reasons why it requires a lot of sperm to get through is because there are a lot of layers of the granulosa cells, and it's the release of these enzymes, particularly things like hyaluronidase, which breaks it down and it finally lets one sperm in. And within 30 minutes, then the sperm head and the oocyte fuse, and you have a fertilized egg. Yes. Now, and the reason why you need a lot of sperm then is you need a lot of release of this enzyme, and one sperm doesn't carry enough. It's kind of neat. Well, nowadays there are just incredible pictures, and so I couldn't resist doing that. And so these are a number of pictures of sperm, of course, surrounding an ova. And in one case here, you can see where the acrosome, the head, is helping to get through in there. And it's just, and these pictures are just so marvelous to see these days. Now that we know, very generally, of course, the anatomy and physiology of the male reproductive tract, we can talk about alterations that can occur. And we can kind of summarize it by saying that the male genital system is susceptible to the following congenital disorders, not so surprising, either acquired or infectious disorders, and even some neoplastic disorders. Well, when these occur, what's going to happen? It's going to affect urinary excretion, sexual function, and fertility, because that's the purpose of the genital urinary tract. We shall start our discussion with disorders of the penis and the male urethra, and there are a number of different congenital anomalies that do exist. Micropenis is one of them. It's the penis is normally formed, but it just seems to be a little on the small side, and this seems to be due to defects in testosterone production. So, with these children, you want to check for endocrine abnormalities and then give them testosterone. Urethral valves, the posterior positioning of the valves are one of the most common reasons for urinary obstruction in male newborns and infants. Seems to be due to an abnormal insertion or persistence of the Wolffian ducts. It's a congenital disorder. Will present usually with an inability to void shortly after birth, maybe about 48 hours. If it's really severe, you can see hydronephrotic kidneys, so there's that much of a backup, renal failure, and azotemia. If, however, you've seen in an older infant, then usually because of the obstruction, there'll be a urinary tract infection with hematuria, and of course, there's straining to void. Treatment, of course, is treat any fluid imbalances that there might be there, and then surgical repair. Other congenital abnormalities include urethral rectal and vesical urethral fistulas. This is where you have a communication either between the rectum and the urogenital tract, and kids can actually pass fecal material and gas through the urethra, and the urine may drain through the rectum. So obviously, this needs to be surgically corrected. Spadias. Now the urethra meatus is located on the ventral or undersurface of the penis or even on the perineum. So again, you got to repair that. And epispadias, the urethra opens on the dorsal aspect of the penis, and this is going to be a point proximal to the glands. They actually have stage surgical repair for this to reconstruct the bladder, neck, and functional urethra. And these, the hypospadias and epispadias, seem to be fairly common. When I was working at the medical college, I was on the research committee, and the medical college had startup funds for, a new faculty and this sort of thing. And I got involved in reviewing a grant from a surgeon who was looking at different things to use during these particular types of surgeries. And he would see upwards of 20 or so of these a year. So it's not all that uncommon. This is just, a stylized picture to show you where the urethra and everything would be with an epi versus a hypospadias. I always want to say spadias. I'm not exactly sure why. And these are some actual pictures showing you the abnormal placement. And these can all be surgically corrected, which is good. And a final picture. I think actually this is probably just a black and white. Yes, it is indeed of two of the ones in the previous slide. Now, there are a number of acquired disorders that men can have. Priapism is one. It's this persistent, painful erection that can last for several hours. Most of them are idiopathic. We really don't know why they're occurring. After that, the second most common reason for this is sickle cell disease, certain anticoagulant therapies, possibly diabetes, leukemia, anything that's going to affect drainage, certain antidepressant medication, and then, of course, some of the drugs for impotence. What's happening is, well, usually there's an obstruction of the venous drainage, and this is going to result in a buildup of um, basically blood in there. It is going to be thick and it's not going to be well oxygenated. And if this goes on for too long, actually, fibrosis can occur, and this can lead to impotence in men. So it can be a serious situation. So your treatment, of course, is going to depend on what's causing this. For anyone with sickle cell disease, sedation and oxygen, and then they may have to aspirate the blood or inject certain alpha-adrenergic agents to, and surgical shunting to try to drain the blood. Two other acquired disorders include phimosis and paraphimosis. Phimosis is when you have an uncircumcised foreskin that can't be retracted over the glands. And this is usually because of chronic inflammation, and this is usually just due to poor hygiene. So, treatment for this, antibiotics and circumcision. Then the problem will go away. Paraphimosis is when the foreskin has been retracted over the glands, but now can't go back to normal position. Again, because of chronic inflammation under the foreskin. Treatment again to reduce the foreskin back over the glands, and you try to compress the glands, reduce the edema. And sometimes actually add a little slit, or it seems to me with that situation, circumcision is would seem to be the easiest. But I understand why guys are a little hesitant with that. And this is a stylized drawing, of course, of those two disorders. The next disorder, I'm never really sure whether it's pronounced Peyronie or Peyronie. Anyway, this is where a fibrous plaque actually forms on the surface of the corpora cavernosa, and this can actually cause curvature of the penis, which can be painful and, of course, lead to incomplete erections. Conservative therapies with things like vitamin E and Patava have had limited success. Nowadays, they have these surgical grafts, so you can take away the scar tissue and put something else on. Urethral strictures form because of scar tissue, and of course, they lead to narrowings of the urethra, usually due to infection or some sort of trauma. Again, symptoms would make sense: a decreased urinary stream and discharge, and because of retention then of fluid, bladder infections as well. And so you got to open it up. Erectile dysfunction is or impotence is another, of course, acquired disorder, unless, of course, it's referred to as primary impotence. And this is usually due to either a deep seated psychiatric problem or some vascular trauma. But it's defined as a man who's never been able to achieve an erection, as opposed to secondary impotence, which is the more common, where they've had erections, but then for one reason or another cannot sustain one at this point. Of course, one of the most common reasons is peripheral vascular disease from diabetes, but certain antihypertensive and medications, as well as antihistamines and antidepressants, can do this. Of course, endocrine problems can also have affect this. Sorry about that. Um, as well, pituitary dysfunction, as well as testes failure in producing testosterone. Trauma, obviously, and psychological causes can all lead to secondary impotence. Treatment will depend, of course, on the actual cause, but there are surgical prostheses that can be put in. Also, of course, drugs and or injection of certain vasoactive substances such as prostaglandins. But the drugs, of course, are the things that we see the commercials about all the time. But it's kind of neat, actually, how they work. Viagra, which of course was the first one to come out, actually inhibits a particular enzyme, and this enzyme has a long name: cyclic GMP. GMP stands for guanosine monophosphate. So this is one of the nucleotides, only instead of being triphosphate, it's a monophosphate. And it is a cyclic GMP, that's what the little C stands for, specific phosphodiesterase type 5. So fortunately, we abbreviated PDE5. Now, when there is an erection, it's very dependent on nitric oxide, which we've talked about before. And you should, at this point, have in your brain sort of permanently, at least I hope so, that it is a vasodilator. And as a result, it also will stimulate the enzyme guanylate cyclase. And guanylate cyclase makes cyclic AMP. So when nitric oxide is released, the cyclic GMP levels increase. Now, cyclic GMP actually it causes the relaxation of the smooth muscle and also increases the inflow of blood. So what does PDE do? It breaks down cyclic GMP. So Viagra levels actually increase the levels of cyclic GMP by inhibiting the PDE, and that helps to sustain the erection. Okay. And the nice thing about it is it says it has no effect in the absence of sexual stimulation. We'll discuss infectious disorders a little bit briefly here because we do have a chapter coming up on them. But of course, gonococcal urethritis is one. It is caused by the bacterium known as Neisseria gonorrhea. This is a gram-negative diplococcus that, of course, is acquired during sexual intercourse. It will, in men, produce an urethral discharge and a burning sensation during urination. Complications because of repeated infections. You can get fibrosis, so you can form urethral strictures. Abscesses can form from this, and even fistulas. Treatment, because the organism has become a bit antibiotic resistant, is, of course, the third generation antibiotics. There's also a non-gonococcal urethritis, of course, caused by other organisms, including the most common Chlamydia trachomatis or Ureaplasma ureolytica. Clinical manifestations: see gonorrhea, and treatment for those usually tetracycline or erythromycin. And then, of course, syphilis can occur. This is caused by a spirochete bacterium by the name of Treponema pallidum. Clinical manifestations, of course, there are 3 different levels, and we'll talk about this in a later chapter. But the primary infection gives you a painless shallow ulcer or a chancre, and diagnosis is through antibody titer or the old test VDRL. And treatment, unfortunately, syphilis has remained fairly susceptible to penicillin, tetracycline, or erythromycin if the patient is allergic. Genital herpes, we have to talk a little bit about. Again, we'll talk a little bit more. Remember, herpes infections are for life, and the classic herpes virus that causes genital herpes is type 2, although rare infections with type 1 can occur in that area. Of course, this is recurring painful vesicles on the genitalia, and fortunately, we do have a drug known acyclovir, which actually inhibits the viral DNA polymerase. We're lucky in that herpes does have its own DNA polymerase, unlike many other viruses. And then, of course, genital warts caused by the human papillomavirus, also known as Condylomata acuminata. Anyway, they're warts. They can be on the penis, the urethra, or the anus, and they have topical application or electrocautery to remove it. And of course, we'll talk more about that when we talk about women's disorders as well. There are neoplastic disorders of the penis, but they're fairly rare in the United States and other developed countries and every place where men are circumcised. And this is because the etiology or highest risk factors being phimosis and chronic inflammation, which occurs with people who are not circumcised, is a predisposing factor. So that's why it's not really seen that much here. Usually these tumors are squamous cell carcinomas, and they, again, arose because of the chronic inflammation leading to activation of the cells and this sort of thing. And when they do metastasize, it's via the lymphatics. So prognosis and treatment, as always with cancer, depends on how far it has spread. Next, we can discuss the disorders of the scrotum and the testes, and we'll start off with the congenital disorders. I always have problems with this one too. Cryptorchidism, hey, I got it, is going to refer to any testes that occupies a position, of course, outside of the scrotum. It seems to be related to incompleted descended or ectopic testes, and this could be because of a defect within the testes or some sort of hormone deficiency. Anyway, the clinical manifestations are the testes don't descend, and there's an increased incidence of testicular tumors later in life as a result of this, and of course, also infertility. So, surgery or injections of HCG seem to help stimulate the descent, and then the subsequent problems usually do not occur. And this picture, of course, is showing you sites of ectopic testicular tissue. And if this were in a female, it would look not all that dissimilar for sites of ectopic endometrial tissue. So it's kind of interesting, although some of it, of course, isn't going to happen because, the anatomy is a little bit different, of course. Other congenital or acquired disorders include hydrocele, and this is when fluid will collect around the testicle, sometimes the spermatic cord, and this can lead to scrotal swelling. Again, you see this predominantly in young boys. Seems to be congenital or maybe as a result of some sort of injury, therapy, infection, this sort of thing. It's in older men, we really don't know what the cause is, so it's idiopathic. Um, Most of the time, there aren't that many clinical manifestations unless it begins to affect the circulation. So the treatment is not to do anything, again, unless it affects the circulation or becomes uncomfortable, and then you got to drain it and resect it to prevent recurrence. And you can see a picture here of hydrocele. Spermatocele is similar. It is, again, a cystic mass, usually painless, but now this contains sperm. We're not really sure what causes it, but we don't do anything unless it bothers the patient, in which case it is then removed. Testicular torsion is when the spermatocords actually twisted. And as a result of this, of course, this can compress the vascular supply and cause ischemia, followed by infarction. And it is occurs in prepubescent boys and is supposed to be very painful, which of course when you see the picture it does look very painful, and it's going to be just in one testes, and of course it's going to be followed by the pain and severe enough where they could be nauseated and start to vomit. Um, this can be serious. They could lose the testes if it's not corrected within 12 hours, and they need to correct it surgically to open it and untwist the cord. And of course, you can see this picture, and although it is a stylized drawing, you can see how, if something gets that twisted, how it's going to compress the blood vessels and lead to ischemia. Infectious disorders of this area include epididymitis, which is inflammation of the testes. It's bacterial infection, usually sexually transmitted disease. Trauma or reflex of urine, however, can also cause it. Again, manifestations of infection, fever, urethral discharge, but the scrotum can be enlarged in these cases too and rather painful. May lead to cystitis and cloudy urine, and because it's an infection, you would expect to see an elevated white blood cell count. So, bed rest, scrotal support, and antibiotics should treat this fairly well. Now, another one, which the book says is uncommon, but I've had the nurses in the past who work at the VA and say it's not is all that uncommon, is this Fournier gangrene, where you have a gangrenous infection of the scrotum. Underlying disease is diabetes and or alcoholism. So it's not surprising you might see a little bit of this in the older VA population. And this is very serious, so you have to get in there quickly and then size it and drain it and correct it that way. We also need to talk about testicular cancer. This is not a very common cancer, but for men between the ages of 20 to 35, it is common. I mean, if they're going to have a cancer at that age, then it's usually testicular, but it's still not very common. Um, it's idiopathic or associated with, I hate that word and I'm not going to try to say it again. Anyway, so, the lack of descent of the testes. Anyway, because of the different types of cells within the testes, they can be either germinal, which are the most common, and there are 5 different types of those, which we're not going to go into, or non-germinal neoplasms. Treatment's going to depend on the type and staging, of course, of the tumor. Um, However, this is actually, if you've got to get a tumor at that age, this is the one you want because it responds really well to treatment. However, if it has spread, and it will do so through the lymphatics, the survival does decrease. Now, no discussion of disorders of the male reproductive tract would be complete without a discussion of disorders of the prostate, which is some of the more common ones. So we're going to start off with the benign prostatic hyperplasia or hypertrophy, in which case both. So don't worry, people. If I ask a question about this, obviously both hyperplasia and hypertrophy will be included in this. Anyway, it's very common. 80% of the men over 60 years of age experience this. It is not related to prostate cancer because studies failed to show an association. But of course, you always worried that it might proceed, even though there has been no association. Anyway, exact cause is unknown. We think it may have to do with the older men's endocrine system. Somehow the communication is out of whack, and so the tissue continues to divide and increase in size. Well, as a result of the hyperplasia and hypertrophy, the prostate gland simply surrounding the urethra increases. This compresses the urethra and produces the symptoms of bladder obstruction. And this is a picture showing you that as it increases, how it would impact, compress the urethra. Not surprisingly, then, clinical manifestations include a decrease in the force of the stream, maybe hesitancy, difficulty initiating it, or it gets interrupted once it's started. And because there's a bladder obstruction, this can lead to infection. Diagnosis then is going to be recognition of the characteristic symptoms, a rectal exam showing an enlarged prostate IVP, and then, of course, they would do a biopsy to make sure it wasn't cancer. Treatment, you may, if it's severe enough, surgically want to remove the obstructing tissue or medication to block the sympathetic alpha receptors or try to prevent conversion of the testosterone to dihydrotestosterone, which would, in theory, and which does work, stop the hyperplasia of the prostate and so alleviate many of the symptoms. And this is just kind of a nice little picture showing you the different complications that can occur as a result of BPH, where you could actually lead to hydroureter and hydronephrosis if severe enough and left untreated. Prostatitis is an inflammation of the prostate. It can be acute or chronic as a result of bacterial infections, but also you can have a prostatitis that's non-bacteria or something kind of weird called prostatodynia. And we'll describe what that is. Anyway, most of the time it's an infection by gram-negative bacteria as a result of an indwelling catheter. Clinical symptoms then, signs of acute inflammation, fever, chills, low back pain, may have some problems with urgency, frequency, and pain on urination. And the prostate can get, of course, swollen as a result of chronic symptoms. They're going to have more of the voiding symptoms, but no fever. If it's non-bacterial, you'll see voiding symptoms. And if it's this prostatodynia or prostatodynia, there we go, got the emphasis correct, the voiding symptoms, but there's no signs of inflammation, so we're thinking spasms, especially if there's no history of urinary tract infections. Anyway, for the first three, even if it's non-bacterial, you consider bacteria, and so you give antibiotics and then oral anti-inflammatory agents, and massage and sitz baths can also help. And this picture just kind of shows you how bacteria can get into the site and cause a prostatitis from different areas. And this picture just kind of shows you how bacteria can get into the site and cause a prostatitis from different areas. Diagnosis is going to depend on medical history, their symptoms, avoiding symptoms, a palpable mass, and of course, an elevated PSA. Although it should be noted that PSA is elevated with BPH as well, so that's not diagnostic. That's why you have to do a biopsy and look at the cells themselves. Treatment, oh, talk about an area of controversy. Obviously, it's going to depend on the stage of the tumor, but also on the age of the man at the time of diagnosis. Um, because, of course, what they want to do is remove the prostate, get rid of the primary tumor and the surrounding tissue. But that leads to some complications that I can understand why men really don't want to deal with, and that's impotence and urinary incontinence. Since a lot of prostate cancers are slow growing and men have a normal lifespan and do not die of it, the question becomes, why treat it? And so there's a lot of argument about it. Of course, others are more aggressive, and if we could determine which ones would become more aggressive and which are more likely not to be, and this sort of thing, and that's many of the things that are ongoing, research that's evolving with that, and but there is a lot of good work that's being done, and hopefully we'll get to a point where if something needs to be done, the men don't have to suffer such consequences, which would be really nice. So that completes our discussion of the male reproductive tract and their disorders. And I will be joining you with the female reproductive tract and their disorders, which, sorry guys, happen to be a little bit more complex, but they're not surprising because women, of course, are able to bear children. So it is going to be a little more complicated. All right, I'll be talking to you soon.